Good afternoon, everyone, and thank you for joining us today in CBA and Amgen. We appreciate you for joining us for our fireside chat on Asthma Peak Week, the perfect storm. Our moderator today is Katie Rokowich. Dr. Katie Rokowich earned a Doctor of Pharmacy degree from the University of North Carolina at Chapel, Virginia Commonwealth University Health System for more than 15 years before transitioning to her current role as a medical science liaison. As both an advocate for and a recipient of biologic therapy, Katie recognizes the impact that scientific advances can have to improve the lives of patients. She is an advocate for improving access to these therapies and has a unique understanding of the barriers that exist. Katie resides in Richmond, Virginia, with her husband, 2 dogs, 2 children, and 2 dogs. And our presenter today is Michael Lindsley, MD, PhD. Dr. Lindsley is a physician scientist and a board certified pediatric allergy and immunology physician. Before joining industry, Dr. Lindsley was an NIH funded researcher based at Cincinnati Children's Hospital Medical Center, where he trained with mentors Mark Rothenberg, MD, PhD, and Nehru Hershey, MD, PhD. He has extensive clinical experience managing pediatric allergic diseases. He also has a special interest in the genetic epigenetic mechanisms which alter normal immune function in both common polygenic diseases like asthma and in rare monogenic syndromes like primary immune deficiency. His previous independent research focused on pediatric onset asthma and congenital epigenetic immune deficiencies, as in Kabuki syndrome associated immune deficiency. His professional focus is to improve symptom control and quality of life for patients suffering from serious immune-mediated diseases. Welcome, Katie, and welcome, Andrew. Thank you for joining us. The floor is yours, Katie. Thank you.
Thanks, Angela. Before we get started, a few housekeeping concerns. First and foremost, we would be happy to answer your questions and comments as they come up, should there be time at the end. To ask a question, please utilize the chat function. It should be noted that we're not able to answer either personal or medication-specific questions during this call, and we encourage you to consult your healthcare provider should you have questions of this nature. For more information about Luma or to schedule future programs, you can visit our website, which will be available in the chat. As Angela said, my name is Katie Rokowich. I'm with Amgen, and I'm a medical science liaison for the Learn to Understand and Manage Severe Asthma program.
Oh, and hello, I'm Dr. Andrew Lindsley, and I'm a pediatric allergy immunologist by training, and I'm a medical director in the respiratory and inflammatory area at Amgen. So today we're going to discuss a very well-recognized phenomenon in asthma called peak week. Now, I first encountered peak week when I was a resident in the emergency department during my first fall working in that space. And along with all my colleagues, every year since, I've helped the emergency room team manage the flood of asthma exacerbations that come in every fall. So this is something that unfortunately we're all in the midst of right now during this time of year. And so hopefully the discussion we have today will be very valuable and relevant to everyone in their day-to-day lives right now. So I'll pass it back to you, Katie, and we can dive into the details of peak week.
Yeah, Andrew. So the first question I have about peak week is, does peak week affect just children with asthma, or are adults also affected?
That's a great question. So, peak week is relevant for all asthmatics, but the phenomenon was first recognized in children. So, studies over the past 3 decades have demonstrated a strong association between the timing of the peak in September and the start of the school year following a summer break. So, in fact, the peak in emergency room visits for asthma among school age children consistently occurs about 14 to 21 days after the restart of school. And in many locations, this corresponds with the third week in September, so basically now. And although it's most pronounced in children, a similar peak is observed among adults. And this is a little bit, there's a little bit of a lag in that adult peak that can happen a week or two later, so a little bit into October for the adult peak. So because exacerbations peak for children, adolescents, and adult at slightly different times in the fall, this period is sometimes called the asthma fall peak rather than just peak week. If you go online, if you search peak week, it's usually the third described as the third week of September. But we now know that it's really the whole month of September and maybe even bleeding in October. One other quick little factoid I'll throw in there as well is that peak week, which is the seasonal spike in asthma exacerbations, this event occurs in North America, in the northern hemisphere, in the U.S. and Canada and Europe and Japan, right around September. But our colleagues down under in Australia, in the southern hemisphere, where all the seasons are flipped, it actually occurs in February for them. So it seems very much to do with the change in the seasons and with the change in our lifestyles and activities, with returning to school after a long summer break being a major part of how it gets kicked off every fall.
So you mentioned that it can be seasonal. What are other causes for peak week?
So it's been hypothesized that upon the return to school, children are exposed to respiratory viruses. Some of the ones that you may learn about if you decide to kind of dive deep into Peak Week and try to learn more about it is there's something called rhinovirus, and that just is the viruses that collection of viruses that can kind of go into your nose, and these are the ones that are most closely associated with asthma exacerbations. So their transmission peaks in the fall. But also, in addition, children may be exposed to an increased level of both indoor allergens, like house dust mite and indoor mold, and outdoor allergens, like ragweed and molds that develop in the soil and on the dead leaves on the ground during the fall. So, what we have found, though, is that this perfect storm is not only the cocktail of viruses and allergens, but also there's a human component to it as well. There's a concern about inadequate adherence to our medications. And this is a very natural phenomenon. During the summer months, a lot of people they kind of fall off taking their medicine every single day for their asthma. And this is really because many people's asthma seems to kind of get a little bit better during the fall. It's the time when there are the fewest exacerbations. So it really does make sense that maybe people might dial back a little bit, but then they're not ready for the whammy that hits them in the fall when they come back to school, when grandchildren and children go back to school and they're bringing things home. The air is full of pollen and other triggers, and we're spending more time inside, so we get exposed to indoor allergens as well. So altogether, this perfect storm of exposure to respiratory tract and viruses, allergen exposure, and diminished adherence to asthma control medicines result in the worsening asthma and result in this spike. So another really interesting part of the story is there is a subsequent increase in healthcare utilization amongst adults, as I mentioned, a few weeks. It's kind of like an echo of that first big peak, but it's more in adults. And this peak is because it's thought to be because of children bringing respiratory tract infections home upon visiting going to school, and they can bring it to home, they can visit, they can bring it home, they can bring it to visits to older relatives, and it can kind of then cascade through that child's network, and children pass that infection to their parents, their grandparents, aunts and uncles, and that takes several weeks to kind of pass along. So you get that kind of echo peak at the end of September, beginning of October in adults. Some other factors that are associated with that increase in asthma morbidity amongst adults is exposure to all the aeroallergens we talked about. Ragweed is a particularly a troublesome one for us in North America because that peaks right around the exact same time that all the viruses are in circulation and children are returning to school. In addition, cold weather starts up at this time as well, and that brings more people inside. They're shutting up their homes a little bit more tightly, and all the indoor allergens can kind of concentrate as well. So it's really this cocktail of outdoor allergens, viruses, and then indoor allergens like the cat and dog dander, the dust mites, and the mold.
It seems inevitable that patients are going to get hit. What can they do to start to prepare for peak week ahead of time?
Well, I fear saying this because I know for many of our listeners they'll be like, well, I can't do anything about that. But one of the key things is that preparation begins in the summer, right? So like so many things in medicine, prevention is usually the best medicine. And so I completely sympathize with our listeners that might be like, don't I wish I could go back in time and be a little bit more adherent with my asthma medicines. But it's important to hear that and to be aware that even though your asthma symptoms might feel like they're better during this summer, the underlying problems in your lungs that are driven by your immune system are always kind of there below the surface. And when the triggers return, the symptoms return. So you're just having a little bit more vigilance during the summer and reminding oneself that it's important to take even when you feel fine is the key to prevent a really bad spike when the fall kicks up again. So patients should be taking all their preventative asthma medications year round, and especially through the late summer. Um, so this, I think, as I said before, there's a false sense that people's asthma has gone away during the summer, and that's just unfortunately not true. It's just below the surface, waiting for the triggers to come back. I'll also call out that the asthma peak is something that appropriately has gotten more and more attention, and so you might be seeing in emails from advocacy groups uh, discussions about peak week. Some of our advocacy partners that we work with in the asthma space. Are very good about drawing attention to that. And also, you might see it in the media as well. And those are nice little reminders to kind of if you did have a little bit of adherence drop off during the summer, jump right back in. It doesn't mean you should wait if you suddenly realize had not refilled your asthma controller medicine to do it until you have symptoms. The medicine takes about a week or two to start working, and so you should immediately refill it and get back to taking the daily preventative medicine. Um, Another important part of asthma peak preparation is by having an up-to-date asthma action plan. And I know we're going to talk about that a little bit more in a moment, but that really is the result of a good interaction with one's physician and having a strong therapeutic alliance there so that there's a plan in place so you know what to do. Because the last thing you want to be doing is scrambling to try to come up with a care plan when you're having difficulty breathing. So that's what the asthma action plan is all designed to do, is to help you be ready when the exacerbation comes. Some other very useful simple things that we can all do and that we've all learned so much about during the pandemic is the importance of hand washing, right? It seems like such a simple intervention, but it makes all the difference in the world in terms of the transmission of viruses and avoiding triggers. If you for example know that smoke is a trigger for your asthma, as one should try to avoid wood burning fires and tobacco smoke, and even that secondhand smoke or third-hand smoke on people's clothes can trigger people's asthma. And so while I don't want to take anyone away from fun family time events where there's a wood burning fire or a campfire or s'mores are being made, you do have to protect yourself from those triggers. um, Another really very practical thing to do is to have a HEPA filter. And so that's HEPA filter, and that's a standalone device you can have in your home, or it can be a HEPA rated filter that slides into your HVAC system. And if you're not sure how to change those filters or what to do, you can ask ask your physician, or you can ask the person who's in charge of the heating and cooling system in your home if those filters are being changed regularly, because the HEPA filters are very thick and they easily get coated and covered with dust and allergens, and they're less effective then. And so they should be checked every 2 to 3 months. And so that's an important thing to do. And one little word of caution there: if you're the asthmatic and you're the one in charge of the HEPA filter, you should be always carrying a plastic bag with you that has a cinch on it. And as you're changing that HEPA filter, it should go directly into that bag. Don't walk through your house with it, because it's going to spread everything everywhere. It should go from the HVAC system directly into the bag. Cinch it, close it, even double bag it if you're very sensitive. One fallout from the pandemic is lots of us have those masks around, the KN95 mask. Throw that on. Do everything you can to minimize exposure to that dust, because that can set off exacerbations. So that's a very important one. Another great one to think about for those of us that are house dust mite sensitized is to think about house dust mite control measures. So I know it's early in the morning for me, at least. I don't want to gross anybody out, but house dust mites are these tiny little critters that live in the bedding and in carpet in our homes. And they're not fleas or lice or anything. They're actually not very interested in human beings. They're not there to suck our blood or to bite us or anything, but they're the cleanup crew, and they eat all the dead skin that we shed off our bodies. And unfortunately, the poo that they produce is what people become allergic to. And so house dust mites are something that a very, very large percentage of people become allergic to, both in childhood and in adulthood. And it's a common cause of triggering asthma symptoms. And so what we want to do is try to control those house dust mites. And that the key to that is humidity control, because the humidity is what regulates how quickly those house dust mites grow. And then also bedding encasement. And so that would be house dust mite proof special mattress covers and pillow covers. These aren't just like, the kind of covers that are fitted sheets that protect the mattress from accidents on the bed. These are 360-degree sealed sheet covers that the whole mattress slides into and you zip, and that stays on. Maybe you take it off once a year to wash it, but that stays on, and it entombs those house dust mites in that mattress, so they can't feed and they can't get moisture and they die. So that is a critical part of controlling house dust mites. And then one other aspect that sometimes is controversial with patients is humidifiers, right? Lots of humidifiers are out there. A lot of people swear by them for helping with respiratory symptoms, but the evidence, the actual scientific data on that is very inconclusive that they're helpful in that way. And we do know that house dust mite populations are controlled by the amount of humidity in your home. The more humid your home is, the more those house dust mites can explode in their population. So we really, in the allergy world, we really prefer dehumidifiers. If you live in a northern part of the country and it's already cold and dry enough, you don't have to add one on top, but just avoid adding additional moisture to the home that not only affects house dust mites, but it makes viral particles in the air persist longer. They hang in the air longer. They enhance transmission of viruses. They make viral transmission easier the more humid it is in the air. And that's a decent pivot to maybe my last point. I apologize for going on and on, but these are there are a bunch of different things that we can focus on to try to help empower our patients. Is thinking about influenza vaccination. So vaccinations unfortunately have become a little controversial, but they really shouldn't be. They've been a part of asthma management for decades, and specifically at the annual influenza vaccine is considered standard of care in all the guidelines for people who have asthma, because influenza can be a major trigger of not only a run-of-the-mill exacerbation of one's asthma symptoms, but it can land you in the hospital if you have certain other risk factors. So the influenza vaccines are out there right now, and as we all know from being here in the world the last couple of years, there are other viruses out there that are very high profile that have vaccines too. The COVID-19 booster is now available for the newest variants. And then there's a new one on the block too, RSV, that's available for both elderly patients as well as pregnant women to help protect their unborn baby. So those are all very helpful options to consider if you have asthma, and you can discuss those with your healthcare provider or your pharmacist if you're interested in getting that extra protection.
Andrew, can you speak to one of the questions in the chat is whether or not stress triggers asthma? Can you speak to that a little bit?
Absolutely. And stress unfortunately affects all aspects of our lives, and asthma is just one more of those. Unfortunately, it very well can affect someone's asthma and lower the threshold for them having symptoms and an exacerbation. Um, it's funny. Even there's somewhat even innocuous things like breathing in cold air or having a laughing fit or even crying. Some of those emotional things that change the airflow into the airway can trigger an asthma exacerbation or a bronchospasm. One way to kind of visualize it and think about it is that the lungs are kind of like an upside down tree, and our windpipe is the trunk, and it branches off into each lung. And as you go down that tree structure, you can get to the medium-sized branches in that tree that's your lung, and those are the ones that are the bronchioles, and they can shrink down when they're exposed to triggers. Whether that's in allergens, whether that's infectious, whether that's even cold air. And the rescue medicines pop those airways back open. But I always want to emphasize that the simple rescue medicines like albuterol are just a band-aid, right? They only work for a few hours. It's the controller medicines that actually reverse the underlying inflammation. So those patients out there who've been prescribed controller medicines, they should remember that they work in a preventative way, and they have to be taken as scheduled. Most of those are once every, twice a day for most of the inhaled preventative medicines. And that it takes several days up to a week or two for them to reach their full effectiveness. So it's not an as needed medicine. It should be used as prescribed to help prevent those symptoms.
And can you comment a little bit about how to communicate with our healthcare providers and like what an action plan is for asthma?
Absolutely. You know, as a physician myself, I understand that how challenging it can be to provide to spend as much time with every patient as we'd like to, and I think that one of the key general recommendations I would make, whether you're visiting a physician online through a telemedicine visit or in person, is to try to do a little bit of prep work the night before, and so that when you're engaging with the doctor for those precious minutes, that you're able to kind of get all your questions answered. So it's not inappropriate at all to kind of jot down your questions, to make use of a lot of the great resources that are out there that I think we're going to talk a little bit about later on, like the asthma symptom diary. Have that information available so you can have answers ready to go for the physician when they ask you questions about your symptoms, and also that your written questions about maybe triggers or about preventative medicine strategies. All those are ready to go, and you can kind of crank through them. I always think of myself as a physician as being a medical consultant for that patient. I work for that patient, and I'm there to answer their questions and help them control their disease to the best of their ability. And I can only do my job if I have a good interaction with that patient. And the patient is a critical part of that in wanting to engage, in wanting to take some ownership of the conversation as well. So I strongly recommend that. But I think one of your first questions there was about something called an asthma action plan. Now, this is something that the physician generates for you, and it's considered standard of care that you get an updated asthma action plan every time you see your physician about your asthma condition. And it basically what it does is what it sounds like. It has a three-tier layout of what you should be doing for your asthma, and most of the time, those are coded as green, yellow and red, kind of like the traffic light. And green is asthma is doing well. You're on all your regular preventative medicines. These are the medicines you should be taking. The yellow zone is something's changing. My asthma is picking up a little bit. What should I do different? And then red is I'm in a full blown exacerbation. What do I need to do? Do I need to go to the emergency room? What rescue medicine should I be thinking about using? And so that is something that the physician should be generating every time you go in and updating with any sort of medication changes. And if you don't have one, you should ask for one. And it won't be a surprise to the physician. It might be that your asthma, like many asthmatics, is managed by your family medicine doc or your primary care doctor, who's managing, all sorts of different problems. But almost all offices will have that asthma action plan they can generate for you. And you should take advantage of it, and have that with you. You can take a picture of it, have it in your phone. Um, there are lots of different tools that are available online through different advocacy groups that you can take advantage of. So those are the keys to collecting the information through your journal, to having your asthma action plan to guide you in your care and in consultation with your physician, and then to do some of the things we talked about in terms of lifestyle, like avoiding smoke, avoiding things that set off your asthma, like perhaps tobacco smoke, campfire smoke, those kind of things, and protecting yourself with vaccinations that are appropriate for you.
So you mentioned a journal. What all should I put in the journal? And do I actually bring it with me to the appointment?
Sure. So the asthma symptom diary is a great approach, and it can be as simple as a piece of paper, where you're taking notes when you're having symptoms, or you can implement it through apps. There are a couple different ways you can go with it, but I would strongly recommend using that as a record that you can take with you to your physician, so you can share some of the experiences you're having, and not only does it share some of the symptoms, but by dating it and talking about your response to therapies, it provides a lot of relevant information for the physician that's all written out in one place, and they can scan it. Sometimes they'll take a picture themselves and put it into your electronic medical record if you consent for that. And it just provides another level of data to help inform the best approach for you. So I'm going to throw into the chat a couple, I think, great templates that are available for free that are out there. As a pediatrician, I was always a big fan of the very simple template that our colleagues in Columbus, Ohio, put together at Nationwide Children's, and so that's a very simple one that you can download and just print out for yourself. There's our colleagues and an advocacy group we love to work with, the Allergy and Asthma Network, has also put together a really great one that's a little bit more detailed, that also can be downloaded as a PDF, and I'll put that into the chat as well. So they both capture the appropriate information, and it's really just a preference of which one you might prefer to use. But it's a great way to kind of begin to organize your thinking about your asthma symptoms, to provide some concrete dates and times for when symptoms are happening, and if you've noticed any triggers, just to record that. And then when you're on the spot with your physician in a visit, you're prepared. You don't have to try to remember the times and dates of everything. It's already there in black and white.
That makes a lot of sense. And as a newer asthmatic, what might a patient be treated with, or what are some of the medications that are used to treat asthma?
Sure. I'm actually just, it looks like I need to resend those links. So just bear with me for 1 second. I'm doing that right now. Um, Okay, great. So that's an excellent question. Asthma medicines are varied, and there are lots of different types. I got to say, as a clinician, it's not uncommon sometimes for people to come in with like a Ziploc bag full of different inhalers and medicines, and some of them are expired, and some of them aren't even for their asthma. And I completely sympathize with that perspective. And maybe that's the situation of some people on the call, and I don't want to discourage you from doing that. I think it's actually a great approach to bring that to your doctor's office, and they can help you sort through what's appropriate, what's expired, what should you be using, so that there's no confusion. I'm always in favor of getting it all out on the table and getting clarity so that there's no confusion about what to do. So as we look at this pentagon shape with the lungs in the middle, we can see a couple of different critical medicines. And the ones that most of our listeners will be familiar with are the long-acting controller medicines for daily asthma control in the lower left-hand corner, and then the short-acting rescue medicines in the upper left corner. And those are kind of the bread and butter for managing asthma. There are some long-acting medicines that are also combined with a shorter-acting medicine or a bronchodilator. Those have become more popular recently. And there's something called smart therapy, which some of our viewers may have heard about, which also integrates those into a single approach. I'd say the general movement is away from the short-acting rescue medicines and more toward long-acting rescue medicines with or without some inhaled steroid, which is the active component of the long-acting controller medicines. But those are the category that most of our patients will be familiar with, most of our viewers will be familiar with. Unfortunately, many of them will also be familiar with oral steroids. And these are not the steroids that pump you up and make you strong like Arnold or anything like that. Apologies, I'm dating myself for invoking Arnold Schwarzenegger, but and some people sometimes confuse glucocorticoids, which are the class of oral steroids used for controlling inflammation, with anabolic steroids and stuff like that, which people use for illicitly building too much muscle. So oral steroids are an anti-inflammatory, and they're a necessary rescue for a patient who's gone into a full asthma exacerbation. You could use as much short-acting rescue medicine as you want, the albuterol, and it's not going to change the underlying inflammation in your lungs. So while oral steroids are not good for long-term maintenance of asthma, the oral steroids are a necessary therapy, and they're a life-saving therapy for reversing extreme exacerbations and bronchospasm from an exacerbation. So the key to oral steroids is to use them when needed for an exacerbation, and to try to avoid leaning on them for daily therapy for controlling asthma symptoms, because while they're very potent, they have side effects if they're used chronically. And that's if you have been prescribed oral steroids chronically, that's a conversation you might want to engage with your healthcare provider to ask about other approaches that maybe don't rely entirely upon a daily oral steroid. And to that end, there are a number of advanced therapies that land within the biologics medicine category. Those are medicines that are typically a monoclonal antibody, which is a molecule that targets a specific target. You inject it. They typically last from anywhere from 2 to 8 weeks, depending on the type of medicine that you are prescribed. And there are some that are available for home use, some that are available that have to be provided in the clinic by the healthcare provider. But the good news is there are lots of options there. The biologic medicines have recently expanded, and they're a very helpful therapy for people who have severe asthma that's not well controlled by standard of care medicine. So once again, a great conversation to have with someone's physician if their asthma is not well controlled despite good adherence with the normal medications like the long-acting controllers and the medicines I've talked about earlier. So finally, there's the class of medicines that are allergy medicines. And these can be nasal steroids, these can be antihistamines, these can be a class of medicine called leukotriene inhibitors, Singulair, or montelukast is one that someone might be familiar with. That class of medicine, anti-leukotrienes. So those are helpful, but with the exception of the anti-leukotriene, none of them are specifically indicated for asthma. And they're helpful for slowing down postnasal drip, slowing down the inflammation that can happen in the nasal cavity from exposure to allergens that can exacerbate asthma and make asthma worse. But they're not the key medicines. They're a nice, helpful medicine that can help, that you can add on top, But the key medicine for the vast majority of patients out there are going to be the long-acting controller medicines. That's the foundation upon which all asthma care is built. And then you can add some of these other therapies in consultation with your healthcare provider to get your symptoms under optimal control.
Thank you. That makes a lot of sense. And I think it helps kind of put everything into its place. At this point in time, we're going to move on to questions. If anyone needs additional information, you can see our Luma website, but using the QR code. You can also scan the QR code to answer our survey questions at the end. Andrew, one of the questions that came up in the chat is asthma hereditary?
Absolutely. Well, that's an excellent question, and the answer is partially. So I spent a lot of time studying asthma heritability as an academic researcher, and we know for a fact there's certain population groups that have a disproportionate burden of asthma. We know that African American patients do have a higher rate of asthma exacerbations than other populations in the United States. Also, certain Hispanic populations as well are disproportionately affected, like Puerto Rican populations tend to have one of the highest rates in the United States in terms of the occurrence of asthma and the frequency of exacerbations. So we certainly know genetics plays a big role. Unlike a lung disease like cystic fibrosis, for example, which is caused by basically one gene, we know that asthma is modified by many genes, tens of genes, so it's not just a single gene that equals asthma like in cystic fibrosis. It's a combination of variants in a variety of immune control genes that seem to influence susceptibility to asthma. But we also know that on top of genetic susceptibility, that there's certain exposures, both early in life and later in life, that seem to drive the development of asthma. So we have a subgroup of patients that develop asthma early in life, and that would be the childhood onset asthma. And then there's a separate group of patients that maybe didn't really have asthma or were never formally diagnosed with asthma as a child, but then developed asthma in their middle age. And those are two different groups that we think have different underlying genetic triggers and environmental triggers. With the young kiddos, we think that viruses play a particularly important role there. One of the ones, respiratory syncytial virus, or RSV, has long been associated with pediatric onset asthma. And then also another one, human rhinovirus, is also one that's very closely associated with exacerbations. So rhinovirus is basically the common cold. It's out there right now, causing peak week. RSV also occurs in the fall to winter period, and there are a number of therapies available, especially for the youngest patients. If you have an underlying medical condition, there are injection medicines that can protect those very young children that might have or something that puts them at increased risk, like a heart defect or something like that, or another chronic illness. In addition, we have some of the new vaccines that I mentioned as well. So RSV tends to hit the extremes of age. It tends to be the infants and it tends to be the elderly. And so now we have options for both of those populations through vaccines. There's one that recently was just approved for pregnant mothers in their third trimester, that can be given during a window during the third trimester safely. And then the antibodies that mother produces from the vaccine are passed on to the baby and protect the baby for the first several months of that child's life when they're most vulnerable. And then there's also an injection that's available for elderly patients that can protect them from RSV as well. So the big exciting question we have in the pediatric asthma world is, will an RSV vaccine in children change the frequency of asthma? Will it confirm our hypothesis that RSV is important in causing asthma? And so that'll be something that plays out over the next decade. But it's exciting times in the asthma world. We're really beginning to better understand the disease. We have new therapies. We have a new approach to managing it in many cases, and we're hopeful to kind of get the scourge of asthma under better control with a lot of these advances.
Another question that's in the chat that's it's sort of related, but does poor immunity or gut flora either initiate or contribute to asthma?
So the microbiome, we know, plays an important role in lots of different aspects of our health, both from our metabolism to our immune responses. I think that the jury is a little bit out on the specific role of the microbiome in causing asthma or contributing to asthma susceptibility. But it's a very exciting, interesting area of research that continues to be studied and looked at. And actually, I'll even further say that some of the work that's been done in children, especially in Australia, where there's a high rate of asthma, has been looking at the flora and fauna, believe it or not, that live in our nose and our airway. It's not just the gut that has a population of bacteria that live. And have are in a stable population. Our airways, especially our upper airways, also have a constellation of different bacteria that all work together in a complex way to either activate or suppress our immune responses. And so those are also very vigorous and active areas of research right now to understand the airway microbiota as well as the GI gut microbiota and how they influence immune responses that lead to asthma.
So interesting. It seems like we're just learning more and more about asthma every day, and there's a lot of ongoing research that's happening to help, treat our asthmatic patients.
100%. It's a very exciting time in the asthma world. But I think that it's in times like peak week and the upcoming winter that focuses our mind every year because of the burden of the disease is still out there. Unfortunately, every year, several thousand people in the United States die from asthma, which is certainly a horrible outcome, one that, despite all of our best efforts, is still occurring with regular frequency. And it also frequently occurs when people are least expecting it. They maybe had perceived that their asthma had gone into remission, they had gone away, they didn't need their controller medicines anymore, and that does. There are patients that do outgrow their asthma, but that's not something that a patient can intuit for themselves. It's really something that they need to work with a physician to um, to make that determination. And I strongly encourage all our listeners to continue on the preventative medicines they're on um, until they've had a conversation with their physician about the right step to make. And that's very much a part of the whole asthma action plan updates that take place every time someone sits with their asthma doctor to really assess, where am I in my asthma journey? Are my symptoms just hiding because it's a time of year where there aren't a lot of triggers for me and they're going to come back, or is my asthma not well controlled with my current plan, and we need to take some steps to get it under better control. I think one of the most common situations is someone kind of getting beaten down by their asthma a little bit and just accepting a certain level of symptoms and exacerbations every year, that frankly they shouldn't. There are lots of new options and therapies out there, and all of our patients should strive to achieve maximal control of their symptoms through these new approaches.
Yeah, I think that's really true. I think sometimes you don't know how bad you feel until you feel good.
That's an excellent point. Yeah, I think I hear that a lot actually. So,
Yeah. Well, Andrew, that concludes all of the questions in our chat. Is there anything else you'd like to add?
well, I just want to thank the organization for inviting us here today to have a chance to speak about asthma. We feel like it's a very timely moment in our calendar to talk about asthma since it's affecting so many people this time of year. And we encourage everyone to maybe take a quick look at our survey, help us improve our educational materials, as well as visit luma edu.com for more educational resources. And we've also provided some educational resources in the links in the chat as well. So thank you so
Andrew,
much for your attention.
there's one last question that maybe we have time to address. One of the listeners would like to know, does food allergies contribute to asthma?
Well, that's a complicated question. Certainly, food allergies can trigger an asthma exacerbation. and it's particularly dangerous in the case of peanut. Most of the research has been done looking at people who have both peanut food allergy and asthma, in particular poorly controlled asthma, or asthma where the current treatment the patient is receiving is not sufficient to control their asthma. That combination has unfortunately been deadly in a number of cases. So, in terms of the causality, we don't really know a ton about whether food allergy, can lead to asthma. We think that some of the immune processes that might have made someone allergic to a food are involved also in asthma, but most patients who have asthma don't have food allergy. And so we don't really fully understand all the connections, but food allergy is frequently a risk factor for asthma. So when it comes to asthma control and food allergies, there's really not anything that we need to do differently, other than the patient needs to obviously always have their epinephrine auto-injector or nasal spray available in case they have an accidental exposure. And we need elevated adherence in patients that have peanut allergy and asthma allergy. That's the riskiest combination, with maybe tree nut allergy and asthma being the slightly next in line in terms of the highest risk combination of diseases. So always having one's epinephrine rescue medicine available, and then also strictly adhering to the asthma preventative medication that they've been prescribed. Well-controlled asthma with a daily preventative medicine, that person is far less likely to have a life-threatening asthma exacerbation after an accidental exposure to peanut than someone whose asthma is very poorly controlled. They eat that they get that accidental peanut exposure, and it can send them into a life-threatening bronchospasm. So those are kind of the key areas where we need to be most thoughtful and careful about following the treatment plans, both for the food allergy avoidance and having the EpiPen, and then also managing the asthma care with daily preventative medication.
Thank you so much for taking the time to address that question. I think it's a really good one, and it's really important. We'd like to thank you all for your attention today, for learning a little bit more about asthma and your treatment plan, and to Dr. Lindsley for taking the time out of your busy day to teach us all a little bit about asthma.
Hi, everyone. Thank you. Yes, we do appreciate you, Dr. Lindsley. Thank you so kindly for joining us. And Katie, we appreciate excellent webinar, informative questions answered. Just explicitly thank you. And what we would like to remind our audience is that we are continuing the series. So join us on Tuesday, October 24th, 2023 at 1 p.m. as usual Eastern Time for Do You Know Your Asthma Risk? So join us again. We'll send out information. We thank you. Thanks to everyone. Have a beautiful rest of the day, and make sure that we continue to be knowledgeable on asthma. Thank you, everyone. Bye-bye.
Thank you so much.
Bye-bye. Thank you.